Welcome. We're going to wait a minute or two as people roll in, but good morning, everyone. And we appreciate you being here. For those of you who would like to continue in English, just stay put.
Y las personas que deseen escuchar la versión en español pueden elegir el idioma oprimiendo el botón en forma de círculo donde dice español en la parte inferior de la pantalla. Gracias.
Again, welcome and good morning to all of our live attendees today. We are thrilled you are here to engage in our exciting webinar on identifying ableism in integrated behavioral health care. I'm Julie Chronister. I am one of our hosts for the webinar today. First things first, a brief audio description of myself. I'm a white cisgender female, she, her, with light brown hair that's pulled up in the back, and I'm wearing a black V-neck top. I have glasses on and my background is white. I'd like to acknowledge that San Francisco State campuses in San Francisco sit on the ancestral homeland of the Ramaytush Ohlone. I would like to also acknowledge that we work on ancestral lands and waters of many other indigenous peoples and nations in our fieldwork in the Bay Area and around the world. We are committed to ensuring this webinar is accessible to our audience. Closed captioning is available in the closed captioning option at the bottom of your Zoom screen. If at any time your access needs are not met or become not met during the webinar, please send a chat directly to a host or co-host. Access is always a work in progress, so we appreciate your comments and support and feedback. I'm a faculty member in the Department of Counseling. I'm working alongside my co-investigators, Dr. Tiffany O'Shaughnessy and Dr. Molly Streer, who are also faculty in our counseling program. I would also like to thank our graduate assistant, Ro Cordova, who's working hard to stay on top of technical issues, the chat boxes, Q&A, etc. This is our 9th of 10 webinars sponsored by our Equity and Justice-focused Integrated Behavioral Health Counselor Training Project, which is fully funded by the Department of Health and Human Services, Health Resources and Services Administration as part of an award totaling $1.9 million. A couple of things before we begin. If you are one of our HRSA stipend recipients, or you are interested in receiving continuing education units for your attendance today, please pay close attention to the announcements provided in the chat for sign-in and evaluation links. Reminder that this is a live recorded Zoom webinar, therefore the audience is not visible and cannot turn on their video or audio. There will be some time for questions at the end. You can post your questions for our speaker throughout the talk by using the Q&A button at the bottom of your screen. The chat function is also available, but for comments, reactions, and sharing of resources, and that will be moderated by our hosts. If we cannot get to all the questions today, please, we will give you contact information for our presenter. It is with great pleasure that I introduce today's presenter, Nicole Bohn. Nicole is the director of the San Francisco Mayor's Office on Disability. Nicole is charged with enacting the Mayor's Office on Disability's mission, which is to ensure that every program, service, benefit, activity, and facility operated or funded by the city and county of San Francisco is fully accessible to and usable by people with disabilities. In my own words, Nicole pretty much oversees everything related to disability in the city and county of San Francisco. She works with our MTA systems, our parks and recs, our building inspectors, our health and human services system, our city supervisors. She connects people with disabilities and their families to local resources and support. She advises the Mayor's Disability Council and their monthly public hearing. She co-chairs SF's chapter on the World Health Organization Global Network for Age-Friendly Cities, renaming our city's chapter to Age and Disability-Friendly Cities. Nicole has been critical to enacting COVID-related initiatives and actions in our city, albeit vaccine rollouts, working with healthcare, transportation, and addressing the basic needs of our disability communities during the pandemic, and working to ensure our outdoor dining program is as accessible as it is today. Much of Nicole's work and energy is focused most broadly on centering disability equity as the foundation for the Mayor's Office Disabilities agenda, moving our city from thinking about disability from a regulatory and accommodations framework to one of equity for all disabled people in our city and county. Nicole started doing her disability work in '97. She was at University of San Francisco, and then following that at our own San Francisco State University as a director of our disability services, and has been at the mayor's office since 2017. With that, I would like to hand it over to Nicole and welcome you to our webinar.
Thank you so much, Julie, and everyone for having me today. My name is Nicole Bohn. Again, a little description of myself. I'm a white cisgender female with glasses and short brown hair. Today I'm wearing a dark blue V-neck blouse and my background is blurry. I'm really excited to be here today to talk about ableism. I identify as a wheelchair user as well. I've had a lifelong disability. I have cerebral palsy. And so a lot of what you will hear and hopefully learn today is informed by that, plus the 25 years of experience that I've had the opportunity to work with deaf and disabled people. So with that, we'll move to what our objectives are for today. Next slide, please. So today, just as a reminder, we're going to define what ableism is and demonstrate how disability and other constructs help us identify and recognize it. We're going to look at ableist structures and the processes that can manifest within integrated care settings, and then discuss some strategies for enacting anti-ableist integrated behavioral health care. Next slide, please. So to get a little more specific, the agenda today will look like this. We'll have, I'll spend some time on language and definitions, and then move to some ideas of bias and culture, and then the evolution of disability. Then I'm going to talk about some ableism examples that came out of our national pandemic response, and talk a little bit about what San Francisco in particular heard and how we enacted some anti-ableist strategies to kind of help start to give you some framework for then, as we're looking at the integrated behavioral health model in particular, how some of these same things may present in these environments for deaf and disabled people. And then we'll talk about some strategies for integrated behavioral health care. And then we'll leave some time at the end for our questions and discussion. What I'm going to be talking about today is my perspective. It's one person's perspective. It's coming through my lens. I think if you talked to other people with disabilities, or even someone with a different disability than I have, their lens might be a little bit different, but I'm going to do my best to represent what I understand about disability across disability and disability culture. But do know that it is really one perspective, and ableism has many threads and lenses, and so we're only really going to have time for a few of those today. Moving to the next slide then, a little bit about language and the language I'll be using today. For the purposes of the presentation today, people with disabilities and disabled or disabled, and I'll explain that, are going to be used interchangeably. It's always fine to use people first language. There are members of the disability community who identify as disabled from a political or cultural framework, and people who have disabilities who identify as disabled who maybe aren't identified through community, but would be fine with that. So I'm going to be using that interchangeably. Deaf or deaf, so deaf with a capital D typically refers to someone who is natively deaf. Deaf with a little d typically refers to someone with acquired deafness. In that case, I'm not going to be using deaf to equate to disabled, particularly because the deaf community tends to acculturate around language more than disability. and I'll talk a little bit more about that. But when I'm talking about disability community, I'm talking about the collective. So deaf people, disabled people together in community. Next slide, please. Okay, so this is a pretty wordy slide that talks a little bit about what disability is, just to give us a framework for who we're talking about today. So for some, disability is a medical condition or a health definition. And for others, it's one where it's a social impact or a cultural identity, which I'll talk about a little bit more, just to give us some beginning framework. Some people with size and height differences would also consider themselves disabled. They would qualify as disabled under the Americans with Disabilities Act. Some people would not identify as disabled, but they would qualify as someone who would be eligible and protected under the ADA. So some of the disability categories that I'll be talking about today include mobility disabilities. So people with mobility devices like wheelchair users, canes, that kind of thing. Folks with sensory disabilities. When I'm saying sensory disability, I'm talking about folks who are blind or low vision, deaf, or hard of hearing. Cognitive disabilities. So for example, intellectual or developmental disabilities, some learning disabilities, some injury-related disabilities, some folks who would identify as neurodivergent. And then health disabilities, for example, lupus, multiple sclerosis, other pain-related conditions, and then behavioral disabilities also would qualify under the Americans with Disabilities Act technically, and those are psychiatric disabilities. On the right side of this image is an image with an informational sign with many of the symbols that identify access for different disability types. This is the informational sign that we use in the city and county of San Francisco right now. Next slide, please. Okay, so I'm going to spend a bit of time talking about language because one of the ways that ableism can first be noticeable by someone who is deaf or disabled is through the language that typically non-disabled people can use or don't use, but even within the disability community, we use different language also. So I wanted to give some framework for the kind of language that is the most current from my perspective. And then I will talk about some things to avoid and why. So as I mentioned earlier, people with disabilities, person first language is always fine. And then it is also fine to use disabled, deaf, or deaf. The language that you choose to use really also depends on where the person with a disability is in their own disability identity. I'll talk a little bit about that. But people with disabilities, disabled, deaf, or deaf, persons of larger size, little people, a wheelchair user instead of in a wheelchair or wheelchair bound, and disability community, which I've referenced a few times. Now, here are some of the things that we like to avoid. My least favorite, or one of my least favorites, and because I work in the city, this is used a lot. It's one of the things that I'm trying to help us with, is I hear ADA community a lot. What is that doing? That is defining the person through a law and not as a person. Okay, so that is something to avoid if we are attempting to be anti-ableist and using anti-ableist language. Handicapped is another one. That's an old-fashioned word. You may want to try to avoid impairment-based or other medicalized language. Some people with disabilities do use the word impairment themselves, but an example of how you can reframe medicalized impairment language is to think about vision impairment. Instead of saying vision impairment, changing to blind or low vision. And then finally, avoiding words that are in our culture and in our own programs and systems, like special needs, special education, that kind of thing, bound, as I mentioned before. And then the addition of the word the in terms in front of the qualifying disability. So by that, I mean the disabled, the blind, the deaf. That is, and I'll give you an example of that on the next slide of what I mean. So it's hard to keep up with language and definitions, and we recognize this in the community. So a general rule of thumb that I like to try to follow is if the language sounds empowering, it probably is. And if it sounds derogatory, it probably is. And so on the left side of the screen, I have an image of a that's on black and yellow in all caps. It says disability is not a bad word. And this is coming from a place of power, trying to own and help everyone understand that for a lot of people, disability is not a bad word. And it is indeed coming from a place of power. On the right side of the screen, you have a cartoon of that's a color image of a mother and child, and the child is pointing to 4 identical wheelchair users and saying, oh, look, it's the disabled, right? When you see it in and hear about it in framework like this, it's a little easier to understand why you would want to avoid that kind of language, perhaps. Next slide, please. Okay, so now a little bit about definitions. Ableism has many definitions. I chose 2 technical definitions, and then we'll talk a little bit about what they mean. So from the Oxford English Dictionary, ableism is defined as discrimination in favor of able-bodied people, right? And so, but even that definition, because they're talking about able bodies, that leaves out other people with disabilities who don't have physical disabilities, right? And so then another definition is ableism is discrimination of and social prejudice against people with disabilities based on the belief, implicit or otherwise, that typical abilities are superior. I like that definition a little bit better. How this comes through and manifests is ableism will attempt and to fix a problem. So first of all, you're assuming that the person who is deaf or disabled has a problem that needs to be fixed, and it's fixing it through the lens of someone who isn't disabled. So for instance, making decisions that are in the realm of, well, this will work best for me, and I think it works best for most people. So this is the solution that I think we should use, through the lens of someone who isn't necessarily thinking about how that decision would impact the person with disability because they themselves are not a disabled person. Ableism also assigns judgment, either implicit or overt, that assumes that disability is bad, not a good thing to have, needs to be fixed again, unwanted by the person who is disabled themselves. They would rather be not disabled, or they're less than someone who does not identify as a person with a disability, marginalized, less important. I'll get into a few more specific examples about that. It assumes that the majority rules. So 60% of the population said this, and so therefore, if 40% of the population is people with disabilities and they disagree, it doesn't matter because the majority rules. That's what I mean. And then it also assumes that people with disabilities are much fewer than the general population, and then less to be considered in line in for when you're thinking about access, equity, as an afterthought, a reaction to a law, that kind of thing. And then ableism also assumes that you're doing for rather than with the disability community. So an ableist statement would be something like, look at all of these things that we did for you, disability community. We put in all of this accessible parking. This counter or this table over here is for you, wheelchair user. Isn't this great that we have this? That kind of thing. So we'll move on and talk a little bit more about it. Next slide, please. Okay. So ableism is informed by a lot of different factors. First of all, systemic, architectural, and programmatic barriers that people with disabilities are experiencing and still experience every day. Inaccessible sidewalks, streets, counters, information, communication, work schedules that don't work for folks with chronic health conditions or disabilities. Every day, people with disabilities are still encountering some kind of architectural or programmatic barrier. But it is also, ableism is also informed by our own implicit biases and what we think about disability. So as I continue through this session, I really challenge everyone to think about, what do you think about deafness or disability? Is it a good thing? What is your lens that where you're coming from, and how you really think about it inform how you interact with people with disabilities? Our own understanding and competency of the current language is informative. The disability community has a history of oppression going all the way back and still to institutionalization, sterilization of people with disabilities, being left out, left behind, literally can't get in places, they cannot access information. It's a long history that we're still even well after Rehabilitation Act and the Americans with Disabilities Act, we are continually still fighting. And then also ableism can be informed by a lack of cultural identity. So, and what I mean by that is twofold. One is that a lot of people with disabilities are on, when they're in their thinking through their disability identity, might not identify culturally as a disabled person. It also is informed, though, by a lack of understanding that there is such a thing as disability culture. On the right, there is an image of 3 Black disabled people, each with their fists in the air, to help us understand that we've got really still a long way to go in terms of disability equity. Next slide, please. Okay, and so disability history could be a seminar in itself, a semester in itself, but in very quick terms, there's the evolution looks a little bit like this. We really started as folks were coming back from wars in particular. We started in our rehabilitation model, which still exists today, that helps to provide reasonable accommodation for folks and understand the nature of disability through either a medical model where the disability, the condition is the disabling factor, or through a social model which says that the environment, because there are programmatic and architectural systemic barriers, is what is causing my disability to manifest. On the right side of the slide, we have a photo by Anthony Tussler, who is a well-known disabled photographer, Black and white wheelchair users protesting outside of San Francisco City Hall in 1977. And one protester has a handmade sign that says, "We shall overcome." This happened right here in San Francisco. The Rehab Act was enacted and signed into law in 1973, but wasn't technically enacted through action until 1977, 4 years later, when more people with disabilities really said, okay, enough, we really need access now. Then we moved to accessibility compliance and really understanding what those laws and regulations were after the Americans with Disabilities Act of 1991. Then we moved into understanding and thinking about universal design. And for those of you who don't know what that means, universal design is the concept that if you build something that is accessible for, that is barrier free, it is accessible for everyone, and then you don't need to provide reasonable accommodations as often. So an example of a universally designed space would be one that has no stairs, no architectural barriers. It has listening systems for folks who are deaf or hard of hearing. It's got identifiers for folks who are blind or low vision, etc. Then we moved into an understanding of disability culture, where we're thinking it through disability pride. And my disability, the fact that I am disabled, is part of my identity. And there are other people that identify also as disabled. And this is part of my cultural understanding. In disability culture, we are adopting disability as something that helps us define who we are and how we move through the world. And then we're talking about ableism, which is what we're talking about today, which is now what can we do to really reframe how even more how we're thinking about disability. And then in recent years, we've had a lot more conversation around the theme of disability justice. Disability justice says that ableism is one part of something that we're working against, but also disability justice will take into account other factors in addition to disability. So how do race and disability and economic status and other factors inform community? Or how does the fact that we need to work together in interdependence with disabled people and non-disabled people to really make change in the world and across our own community? Next slide, please. Okay, so that was very quick outline of kind of where we've been. Now I'm going to talk about how ableism has really manifest in very recent times. These 4 articles that I've highlighted here, I'm not going to go in each one in detail, but I do encourage you to take a look at these. These are directly from our headlines around. So the first one says, Oregon hospitals didn't have shortages, so why were disabled people denied care? So what was happening in the beginning of the pandemic, as we were making choices nationally about how we were going to respond, people with disabilities were last in line and not getting health care and other things that they needed, especially ventilators, which we'll talk about in a second, as part of the response. So what started happening then was we started having more awareness that disability discrimination was very, very visible and evident. So the next article talks about disability discrimination, medical rationing, and COVID-19, meaning again, when there were shortages, there were decisions being made that people with disabilities who were exceptionally affected by COVID were perhaps expendable. The third article is by our local colleague, Alice Wong. I'm disabled and need a ventilator to live, and am I expendable during this pandemic? So it talks a lot about what are we saying that we're doing this, and saying that people with disabilities don't have the same priority to medical and healthcare as other people. And then finally, I highlighted an article that says the terrible toll of COVID-19 on people with intellectual disabilities. In the beginning of the pandemic, in particular, people with intellectual disabilities were dying of COVID at a higher rate than other disabilities because of a lot of reasons having to do with fear, but also I think just a lack of understanding and confusion and understanding how to help folks. So I'm going to go to the next slide and talk a little bit about what we heard in the disability community in San Francisco. So we had some listening sessions, and we heard fear of being forgotten, feeling invisible, feeling unsafe, navigating retail and public spaces, especially from the blind community, who were saying, we don't know how to navigate now. They're used to navigating through touch much of the time, and or with service animal or a cane. And when your environment changes, that can be very difficult. We heard about the need for barrier-free vaccine access, and then the negative impact that the transportation and the mobility landscape changes have had, and the lack of access to essential technology, the digital divide that people needed in order to communicate during COVID, and then the lack of access to effective communication and information. And part of the reason that I highlight this is because these are things that still come into play and will come into play when we're thinking about setting up our integrated behavioral health environments. These are all concerns that people with disabilities have today and have been especially elevated again through the pandemic. Next slide, please. And so we tried a few anti-ableism efforts in our pandemic response in San Francisco. We helped to distribute personal protective equipment specifically for folks with disabilities. So especially in the beginning of the pandemic, you'll probably remember PPE was very rare. We held virtual community town halls specifically for people with disabilities. In San Francisco, we took vaccine equity prioritization of people with disabilities very seriously. We created barrier-free attestation so that people with disabilities could receive their first vaccine as soon as they became eligible, and would not have to sub-identify or wait until their disability type came up in the queue, which was what most cities and states were doing. We then hosted some community-specific vaccination clinics and transportation subsidy initiatives. And then we conducted a technology needs assessment, which I've also linked to, that I encourage you all to look at. It will talk a lot about what we learned about the way that people with disabilities rely on and technology, which a lot in the field we knew, but we learned a lot of surprising things too, like transitional aged youth with disabilities have specific difficulty with access to technology because they had it in school, and then school goes away and then they lose their technology. And then what does that mean? Right. And so the image on the right side of the slide is two representatives from our colleagues at the SF Lighthouse who are wearing face masks and waiting for others in their lobby. The Lighthouse is one of the places where we held one of these vaccination clinics. Next slide, please. Okay, and so for those of you who had an opportunity to be part of Erica Gomez's The What and Why of Integrated Behavioral Health in this series, Erica talked about barriers to healthcare as transportation, distance, stigma, language, time, and unknown or unfamiliar systems. Many of these things, all of these things, are also specific barriers in the disability community also. Transportation. If you can't get somewhere because transportation is too not accessible or too difficult or too far, you're not going to participate. There's stigma around disability that then, of course, will, for some people with disabilities, encourage them not to participate. Language issues that I've talked about, time, things take longer for people with disabilities. And what I mean by this is because there are architectural and programmatic accessibility barriers, which is the one thing I've added to Erica's list specific to disability, you don't know what you're going to encounter. There's, and so you need to just rely and provide more time for every activity. And that can be very draining and tiring for folks with disabilities. And then unknown or unfamiliar systems. If I show up in that medical provider, am I really going to be able to get in the front door? Are they going to have accessible information for me? I asked for an interpreter. Did they really do it? All of these things are things that folks with disabilities are concerned about. Next slide, please. So, but I do think that the benefits of integrated behavioral health can be a model for anti-ableist environments because of all the things that make an integrated setting advantageous. It can be a lot more convenient and easier and inviting for folks with disabilities. And that's why I think we have a unique opportunity and responsibility in the IBH environment to really create more anti-ableist spaces, which is one of the images I have in the middle, and then work on our attitudes, stereotypes, barriers, and misconceptions that really lend to what ableism is. And then, think about disability culture and the disability justice model with the, in the image on the far right is a Black disabled woman holding a Black disabled lives matter sign. I think it's our responsibility to begin to create these environments, especially in those places where it's easier to do that. Next slide, please. Okay, so how do we do that? So I'm going to spend a few minutes just on a few ideas, and then I really welcome our conversation and questions. So the first thing that I think is that we really need to, in our settings, prioritize enacting disability laws and design principles and provide accessibility compliance training and professional development to all of our staff. And so the first step in providing an anti-ableist environment is really understanding what are the actual requirements that I must follow that have been in place for 30 years or more that can really be supportive of people with disabilities. I've listed on this slide contact information for our Pacific ADA Center, who are a wonderful online and telephone resource. They give a lot of trainings. They are free. For those of you who might not be attending from the West Coast, the Pacific ADA Center is part of a national network. And so there is an ADA Center for your region. I really encourage everyone to familiarize yourself with them because they are all phenomenally well educated, and the seminars and webinars that they provide are really great. Okay, and so another step that we can take together is making sure that we're providing accessible furniture, reception, restrooms, big one, information. And what I mean by this is a lot of the times on our registration forms, how many times have we gone to a provider and you're given a piece of paper and said, fill this out. If I'm blind or low vision, that's going to not be possible. And an anti-ableist perspective would say, have another method, have an electronic way to do that same thing that you can send to someone, or you want to provide information in multiple ways that folks with disabilities can access in different ways if they need to. And complete independently and with privacy. It is not equivalent in my mind to say, well, if you can't fill out this private medical or healthcare form about all of the things that you're thinking about and concerned about today, I'll just read it to you and fill it out. That is one way to do it, but that is not an anti-ableist way. We want to provide it in an accessible way when we can. We also want to make sure we have exam rooms and well-designed counseling spaces whenever we can. And then another way to really think about this is to include deaf and disabled people on your advisory boards and within your employment initiatives. It is always best to learn about disability through the lens of someone who has had direct experience. It doesn't mean that folks that do not identify as disabled cannot teach disability-related concepts, absolutely. But I think that when you're really trying to be anti-ableist, really understanding the perspective through someone who is disabled or deaf is a very positive way to go. Next slide. Okay, and so learn language and avoid inspiration. This is a big one. An idea can be inspired or inspiring, but anti-ableism would say that that the person themselves are not inspiring. So on the left, I have an ableist example of one of those motivational posters that has a woman with a wheelchair with her arms outstretched, facing a very lovely ocean on the beach. And it says, never ignore someone with a disability. You don't realize how much they can inspire you. Right? And then the anti-ableist approach would be of the same statement. On the right, I have an image of a wheelchair user, Stella Young, who's wearing red and white heels. And she is saying, disability doesn't make you exceptional, but questioning what you think about, disability does. Stella is phenomenal. She's no longer with us, unfortunately. She's got some great TED Talks. If you want even more education on her inspiration porn perspective, please look her up. Next slide, please. We are almost done and then time for a few questions, hopefully. Next, another way to enact anti-ableist integrated behavioral health care is to ask for voluntary demographic information. Unfortunately, we don't have a lot of information about folks with disabilities who are accessing counseling or integrated behavioral health because we're not collecting the information to learn. And even in some of our medical procedures right now in forms, I filled out a form last week for a medical survey. I didn't even have a way to identify on this survey for myself that I was a person with a disability. I mean, even the medical form didn't allow me to count for that. It's pretty important. Doesn't define why I was at the doctor that day, but they should still know that, right? So ask the information. Promote how integrated behavioral health model has fewer barriers for people with disabilities because it takes away some of these things that have been barriers like transportation and proximity to services and all of this that we've talked about. Then I would challenge us to avoid assumptions. We want to check your implicit bias. What do you really think about deafness and disability? Talked about that a little bit earlier today. And then I challenge us to do the work to get to the real core and then learning about the deaf and disabled experience directly from folks, avoiding reductionary thinking. What I mean by that is avoiding an assumption that the reason they're in the healthcare setting, in the counseling setting, is because of their disability. Might be a part of it, but it's not all of it. And then you want to evaluate where is that person in their own disability identity. do they identify as a person with a disability? Culturally, do they identify, or are they not there yet in their involvement, in their own evolvement in terms of disability? Okay, and so next slide. And I'm closing with a little bit of anti-ableist humor. Maybe we can have a few questions. This is an image by the cartoonist, disabled cartoonist John Callahan, that I think is a good example of anti-ableist humor. This is a cartoon of a blind man happily tagging the wall with Braille graffiti. So it's anti-ableist because we've flipped our perception of what we might think about what a blind person should be doing, and they should have equal opportunity to tag graffiti if they want to. So this is why I like this image for that. I've provided also the contact information of myself and the Mayor's Office on Disability for your reference as well. And that ends my presentation. It looks like we have some time for some questions. I feel like I went by, that went by so fast. So, but hopefully we can have some additional discussion.
Thank you so much, Nicole, for that amazing presentation and for that information. I think there was lots of things going on in the chat, and we have already several questions. How about I dive right in, and let me start with the first one. What conversations have you heard happening at the county, state, and federal level around acknowledging conditions resulting from long COVID as a disability and therefore be protected under the ADA?
So the answer to that is there's still a lot more work to be done in acknowledging that there are long COVID effects that are disabling. I would say that the challenge for us is to first have awareness that that's happening, and then understand that that is one of the factors that is that someone who would be newly experiencing disability because of the long effects of COVID, all of this information that I just presented would be brand new. I do think that there is more that can be done on state and federal levels, in particular around advocacy for continuing to prioritize disability and disability issues as they pertain to COVID.
Thank you so much. Next question. How do we work with the TSA? I've seen unintentional demoralizing behaviors in the security line, i.e. elderly woman using wheelchair having to stand up to be scanned.
Right. So that's a very interesting question. So because the airline industry is under different regulations than they have different mandates, different accessibility mandates. However, everyone needs to have anti-ableist education. I think our TSA colleagues would really benefit from a presentation like this one. I think too, though, that until we have folks that are, when you see, let me back up and say, when you see discrimination happening, one of the first things that we can do is we have to elevate it. We have to acknowledge it and make sure that we're bringing it forward so that it can be addressed. Because if we don't take that step to do that, it is going to continue happening. And so I think the first step is to say, when you're seeing that happening, follow up, say something, maybe with the person in the moment, but more importantly, talking with with the organization where you're seeing that happening and saying, look, this is happening. This is ableist. This is not okay. you need to get some training and understanding.
I appreciate that, saying something. That's a common thing at the airport. See something, say something. It seems as though this applies here as well.
Yep, yep.
Okay, onward. Recently, there has been an uptick in sweeping streets and disposal of tents belongings of persons who are homeless, including in SF. As we know, there is a significant portion of persons who are homeless that also have disabilities. Will there be upcoming improvements in our tactics to not criminalize homelessness and improve accessibility to supportive resources?
That's a great question. And it's a really important one, because I think in particular, one of the things through now putting on my mayor's office on disability hat, one of the things that we're really working on is with the Department of Homelessness and others are, how do we make sure that as we're doing our triage work in our systems, that we're first of all identifying the person with a disability who's experiencing homelessness, and then within that, prioritizing that person for services and care. And because we haven't historically been doing that consistently, disability in itself has not always been a factor by which then we prioritize making sure that that person is receiving both housing and the resources that they need. I do think that with the additional initiatives that we have around permanent supported housing, and there are requirements that these facilities all have to be accessible and follow accessibility code guidelines, which my office also works on, that it'll continue to be better. But it is something that we need to continue to elevate, acknowledge, and work towards. And it can't be just my office that's doing that, right? This is an example of, through the disability justice lens, where we all need to be talking about this together. So that it's not the disability community keeps saying this, but it's that we're all saying it. And as we're all saying it together in an anti-ableist way, it makes it a lot easier for things to happen.
Thank you. Another question. What are ways that supportive housing can be of better service to folks with mental health disabilities?
Mental health, yeah. So I think first, acknowledging those places where our providers in supportive housing environments need more education around psychiatric behavioral disabilities, and kind of that their own their own biases around that, and really working towards that. I think specifically in when we're talking about behavioral health conditions and psychiatric disability in particular, this community, I hear frequently, really does not feel heard, because oftentimes there's an assumption made that what they're asking for is an interaction of their disability, and perhaps because of this, not something that they actually need. And that makes it challenging. And so I think really taking and making space for safe, protected listening, and then but once we know what the request is and what the need is, it's one thing to know what it is, but then how do we in our systems prioritize it? Because we all have systems, we all have limited budgets, and we need to make choices. And so then I think specifically with psychiatric disability, what can happen is, because of lack of time, because of lack of resources, those concerns maybe can't be addressed in the same way. So again, it comes back to learning and listening, but then also prioritizing what that person is asking for, or what support they're saying they're needing, in the same way that we would prioritize everything else. it's much more challenging and complicated than that, I know. And it's systemic and it's structural, but that is, listening is the first step. It really is. And then elevating.
Thank you so much for addressing that. That's a tough area to address. And I appreciate that question. I have another question. I think we have a few more minutes. How can we advocate for and support people with mental health disabilities at work who struggle to transition back to in-person work, travel, etc., especially if the transition-related fears worsen their mental health symptoms?
Right.
What advocacy can look like if they also don't have access to regular quality mental health care? That's a long question, a really good one, and certainly dovetails off what you've been talking about. Did I get that through okay?
I think so. So I think one of the things that we need to be working with our human resources systems to really allow for accommodation, additional accommodation for people with disabilities that is as barrier-free as we can possibly make it. I think a lot of our HR systems require, and they have the right to require, documentation of disability and reasons for why they're making their request. That is all legitimate. But I think then within that, our HR professionals can continue to help to work with hiring managers to educate folks, and so that they know that there are rights out there. And then also really be thoughtful about that. If someone is requesting part-time work because of disability and they need to work from home for a while because of COVID or because the environment, their navigational environment has changed, that's probably pretty legitimate. And so really thinking about that. And I think one of the things that our HR systems sometimes fail to do too is we're very form-based, right? And so we're filling out all of this information that's on paper, and the part that gets left out is the actual conversation between the HR representative and the person with a disability about what they need. An anti-ableist strategy would invite an actual conversation so that you can make some really legitimate decisions together that are going to work for the organization and for the person with a disability. And then I think the other thing that we need to be doing more of is for those that work in larger organizations, definitely the city is an example of this, is we need to be educating our hiring managers as well on the basics of disability and anti-ableism practices so that folks can recognize it and then move it forward in a way that works for everyone.
Thank you so much, Nicole. We are just about out of time, and I think we've answered all of the questions, and really appreciate your this incredible presentation today and the knowledge you've shared. And is there anything else you want to add before we close out? I just want to thank you so much.
Oh, you're welcome. Thank you everyone for your attention. And I'm really happy to present this today. I could talk about this all day long. And so if there are other questions, my information is in the slide deck that I will be posted, correct?
Yeah.
Later. And I really encourage you, reach out to other people with disabilities, reach out to our Pacific ADA Center or those in your national network, and keep learning. What I presented today was just the tip of the iceberg, as they say. So please continue your education. That would be such a gift for all of us together.
Yeah, lots of thank yous in the chat if you're not seeing them. So again, really grateful for this, and a reminder to everyone that this webinar will be posted on our website in the next week, as well as the accessible PowerPoint. And so that will be available if you want to disseminate that to your colleagues, particularly those working in medical environments. This would be a great webinar to share. So again, thank you so much, Nicole. I wish everyone a great weekend, and see you all soon.
Okay, thank you so much.
Mhm.